Thank you once again for giving us this great lecture. I'm sure plenty of people are just waiting for it. And personally, it's one of my, it's for me, it's a very interesting topic. So I'll leave you the floor, and thank you again for giving us this lecture.
Thank you. Good afternoon, good evening, good morning to everyone. Thank you, Dr. Solara, for inviting me again to this forum and for giving me this opportunity to talk to the participants about imaging specifically oriented at balance disordered patient. In fact, after the last lecture 3 weeks ago on CT temporal, there was a request from some of the participants as per the message sent to me by Dr. Solara about, I suppose the topic that you had mentioned was CTMR in otology. And that is what put the seed of the thought in my mind. And this presentation is a culmination from of that particular thought process that had germinated at that point of time. So let's dive straight into the presentation. As you can see, the presentation is titled CT and MR in a balanced disordered patient, what to look for and when to do. Now, I have taken a linguistic liberty here. I mean, my grammar teachers would probably beat me up for the fact that I'm using the what before the when. I mean, technically speaking, as far as an investigation is concerned, we normally say when to do it and what to look for. But as you can see, what I have written here in the title is what to look for and when to do. Just indulge with me for some time, and I'm sure that I'll be able to justify this linguistic paradox that I've taken the liberty of resorting to by the end of the presentation. Obviously, there's one more question which is left here, and that is which one to do. And again, I hope that by the end of the presentation, you would have a significantly clear idea as to what is it that, when is it that you should investigate, which is the modality of investigation that you need to go in for, and what is it that you need to look for. Right. So okay, let's start off with the very basic. And before I start, let me also emphasize on the participants that this is an otologist's perspective. Rather, this presentation is an otologist's perspective in the sense that I have included cases here, from the perspective of an otologist. So I've left the neurological cases to our neurologist. I mean, I'll leave those to our learned neurologist friends as and when you have a presentation from that perspective. And B, I have only used those cases here, those examples here, which I have encountered in my own private practice, in my clinical practice, in the sense that there could be certain pathologies, certain scenarios of which I might not cover, simply because of the fact that I did not want to take images, radiological images from the net and show them here only to make the presentation more complete. On the contrary, I have taken images, used only those images which belong to me, right? So keeping that in mind, let's first and foremost understand that as an otologist, we routinely see patients with otoscopic pictures like these, right? You know, cholesteatoma, erosion, retraction of the tympanic membrane, granulation tissue, partial erosion of the ossicles, so on and so forth. So, right? So this is a very, very routine scenario for us as otologists to encounter in our day-to-day practice. What happens if such a patient starts complaining of dizziness? If such a patient starts complaining of a spinning vertigo, what is it that you have to keep in mind? What is it that you would look into? And what is it that you might end up finding after investigating the patient? And one more liberty that I have taken here is because it's a pretty long presentation, I haven't gone into the clinical signs and symptoms, the symptomatology or the signs of the patients in details, because I would like to give you the different scenarios that as an otologist you might encounter in in your private practice or in your clinical practice, in case you're dealing with patients of vertigo, I mean, whether disequilibrium or ataxia, whatever. So if this patient comes to you and it's obviously an unsafe CSOM, and complains to you of, I mean, dizziness, you can call it dizziness, you call it vertigo, whatever you feel like, or even if the patient starts complaining of ataxia, there is a condition which could be subsequent to a scenario like this, which could lead to ataxia also to a patient, in a patient. So what is it that I need to look for? Obviously, I'm not looking at just the middle ear disease. There is definitely some kind of a complication beyond the middle ear pathology, beyond the inflammatory middle ear pathology that the patient is suffering from. Now, that pathology could be located within the temporal bone, that is, it could be intratemporal, or it could be outside the temporal bone, but within the cranium, that is intracranial. So in case your suspicion is towards mainly an intratemporal pathology complication, which we'll see in the next slide, then ideally speaking, you should go in for a CT scan first. But in case you're looking at some kind of an extratemporal intracranial pathology, then probably getting an MR would be a better idea. So what is it that first comes to your mind? Patient of unsafe chronic suppurative otitis media, the patient suddenly comes to you complaining of rotatory vertigo without vomiting, and there is a sudden deterioration of hearing. Obviously, the first thing that should come to your mind is a lateral semicircular canal fistula. This is an axial CT of the right side. And I hope there are some of my friends from the previous presentation who had seen the normal anatomy. So this is the vestibule, and as you can see, this is the lateral semicircular canal, the signet appearance of the lateral semicircular canal. But the bone over here on the lateral aspect of the otic capsule is eroded, and not only that, we find that there is a soft tissue isodense shadow here, which is in direct continuity, with this shadow within the lateral semicircular canal. So definitely this patient who probably has cholesteatoma in the attic, the antrum, and the adductus area has developed a lateral semicircular canal fistula. So the first thing that you think of, depending upon obviously the symptomatology of the patient, is the presence of a lateral semicircular canal fistula. Now, a lateral semicircular canal fistula in such a patient could be as obvious as this, or it could be a mere dimpling. So you can see that you can definitely, I hope you can make out the shadow, the faint shadow of the lateral semicircular canal. Again, this is the same patient. This panel here is slightly inferior panel, and this is a slightly superior panel, superior slice. So you can see the faint shadow of the lateral semicircular canal, but what you see more importantly is this dimpling in the bone over the lateral semicircular canal or of the otic capsule. So even if the CT scan does not demonstrate a frank fistula like this, a dimpling over the otic capsule, the lateral aspect of the otic capsule, should definitely raise the index of suspicion, and you have to consider a lateral semicircular canal fistula in such patients. It's the same patient, a coronal view, which very clearly, once again, that's the vestibule. That's the basal turn of the cochlea, that's the lateral semicircular canal, and you can see that the bone which was supposed to be here, the bone belonging to the otic capsule, is missing, and the adductus and the attic area is occupied by an isodense shadow, which in all probability is obviously the cholesteatoma. And also what you can also appreciate here is that the scutum, which should have been somewhat like that, a little more beak shaped, is partially eroded. So lateral semicircular canal fistula. That's another case of a similar scenario. There is an isodense shadow here, which is cholesteatoma. You can see the thickening of the external auditory canal wall, but what definitely you see here is that the lateral semicircular canal has a fistulous communication with the mass in the attic or the adductus area. So repeatedly saying, the first thing that you would think of within a patient with chronic suppurative otitis media, complaining of sudden onset vertigo without vomiting, increase in the hearing loss, as an added sensory neural component to the previously conductive hearing loss, we have to think of a lateral semicircular canal fistula. This is another patient here where not only do you see a fistulous communication between the mass in the middle ear and between the lateral semicircular canal, but you also see that this shadow is isodense. The previous shadow here was isodense, but now what has happened here is that within the isodense shadow of the vestibule and the lateral semicircular canal, there is a hypodense shadow, which means that the fistulous communication actually has led to the ingress of air into the lateral semicircular canal and the vestibule, and such patients are more liable to have vertiginous attacks, and their vertigo is liable to be more severe compared to the previous patients. So these are some examples of a lateral semicircular canal fistula. Beyond that, I mean, is it only the lateral canal which might be affected? Obviously not. I mean, if you have a little more extensive cholesteatoma, something called the petrous bone cholesteatoma, okay, you can definitely have, as is evident on this coronal section, this is the right side, the coronal section on the right side, you can see that the lateral canal, the otic capsule over the lateral canal is intact, but the otic capsule over the superior semicircular canal is missing, and is communicating with the isodense mass in the attic area. Not only that, we see that the tegmen here is partially eroded. Naturally, the tegmen is probably not responsible for the attack, for the dizziness in the patient, but this particular fistulous communication between, I mean, secondary to the chronic inflammatory disease process that the patient has, is responsible for the vertigo in this patient. As you can see, the ossicle here is intact, the scutum is not badly affected, but the lateral semicircular canal is definitely fistulous in nature. Now, this was as far as the intratemporal component of the complications are concerned. Usually, there's not any, I mean, there's no other bony complication within the temporal bone, as far as my knowledge goes, which could be responsible for dizziness or vertigo in a patient. But that does not mean that the patient, I mean, if the bony component is intact and still the patient is vertiginous, either it's a disequilibrium or the patient is having ataxia, the patient might not have any other complication. There are two other complications that have to be kept in mind. In case you've done the CT scan, your CT scan is normal, the patient does have an unsafe CSOM, and still the patient is having either disequilibrium or ataxia, you have to look into the brain. That is the extratemporal intracranial complications, and one important intracranial complication is a large cerebellar abscess. So this is an example of a cerebellar abscess. This is a CT scan. You could do a CT scan, you could do an MRI. So this is a cerebellar abscess. The mastoid is occupied by a by a pathological process. Unfortunately, I could not put in the picture where then yes, this is the picture that I was referring to. Just a moment, please. So let's go to the better picture. So you can see that the patient has a cerebellar abscess in the left cerebellar hemisphere. The patient, this is the mastoid, the petrous bone and the mastoid bone, and there is a shadow within the mastoid bone, and more importantly, the bone over the posterior aspect of the petrous face close to the lateral sinus is eroded. So this patient, rather than a rotatory vertigo, is more liable to complain of ataxia. So this is another complication of an unsafe CSOM, that is a cerebellar abscess, which has to be kept in mind while evaluating a balanced disordered patient with in the background of chronic suppurative otitis media, especially the unsafe type. Okay, so cerebellar abscess. Another example of a cerebellar abscess, a little a little above, which is on the right side. This is another cerebellar abscess that you can see a little above, and this is on the right side of the patient. Okay, so cerebellar abscess is an important complication that has to be kept in mind. Beyond the cerebellar abscess, obviously, you do have something called the sigmoid sinus thrombosis or a lateral sinus thrombosis, which earlier used to be a very common complication, at least in our part of the world, secondary to an unsafe CSOM. But now with the advent of the antimicrobials and better treatment modalities for the patient, it's become slightly lesser. But but we do still see patients who have a sigmoid sinus or a lateral sinus thrombosis. So what happens here is secondary either to a direct invasion of the sinus or secondary to a thrombophlebitis. The lateral sinus on the side which is similar to the side of the disease process gets involved, and there is gradual inflammation and formation of thrombus within the lateral sinus. Now, normal CT scan, this is an MRI, obviously a T1 weighted non-contrast, pre-contrast MRI. So in a normal MRI, the sigmoid sinus or the lateral sinus is not visualized because of something called the time of flight view. So what happens is, because the blood flow through the sigmoid sinus or the lateral sinus is faster, it is not caught up in the routine T1 weighted MR images. But as you can see on the right side, this is the lateral sinus of the patient, which has become occluded with a thrombus, and right adjacent to it, you have this mass in the mastoid and the middle ear. But you can see that in between the two, the hypo intense shadow is well maintained, which means that the bony partition between the mastoid, the posterior face of the mastoid, and this lateral sinus has not been eroded, in the sense that this is not a case of a direct invasion, right? At least in this cut, but rather secondary to a thrombophlebitis. But as we move on to a different cut and as we use the contrast, we realize that the bony partition is actually missing. So this is the shadow within the mastoid antrum. In fact, this patient had this was a patient I had seen long back ago and operated upon long back ago. Anyway, so the patient, as you can see, has some involvement even of the soft tissue, and there is this contrast enhancement of the lateral sinus. You can see that the lateral sinus on the other side is not visualized even on contrast because of the rapid blood flow, but on the right side, because of the sluggishness of the blood flow, the contrast has accumulated in the lateral sinus, leading to a hyperintense shadow with a heterogeneous shadow in front, which is congruent with the area of the mastoid bone or the temporal bone. Okay. Same patient, we go a little higher up above, and we see that not only is it the lateral sinus, you see the lateral sinus on the left side is a continuation of the sagittal sinus. Okay. I'm sorry, the left side, on the right side is the continuation of the sagittal sinus, and on the left side, it is a continuation of the transverse sinus. So as you can see, so if the sinus is progressively getting more and more involved, there is a chance that the sinus could involve the lateral sinus involvement, could involve the transverse sinus, and then even the sagittal sinus. As we can see here, the sagittal sinus is beginning to get involved, and you can see the sagittal sinus involvement here. Very clearly, you can see the sagittal sinus involvement in this particular patient. So another reason for disequilibrium, or rather ataxia, of a balance disorder in a patient in your OPD with chronic suppurative otitis media is the presence of a lateral sinus thrombosis with further extension either into the transverse sinus or into the sagittal sinus, right? Another view, same patient, lateral sinus involved, mass, the inflammatory mass in the temporomastoid region. Same patient, another view, this is the contrast study. So you can see the lateral sinus involved along with the primary pathology in the temporomastoid region. This is an MR venogram of the same patient. So as you can see, the right side transverse sinus is intact. The left side transverse sinus is intact. The left side sigmoid sinus is intact. The jugular bulb is all intact. But on the right side, you can jolly well see that the transverse sinus is absolutely thinned out, as is the lateral sinus, and we do not see the internal the jugular bulb and the internal jugular vein over here, which is another indicator of, it's another investigation that you might think of if your suspicion for lateral sinus thrombosis is very high. Same patient, a slightly different view. So lateral transverse sinus left side intact, lateral sinus left side intact, transverse sinus right side involved. No visualization at all of the lateral sinus on the left side, on the right side. I beg your pardon again. Okay, from the inflammatory conditions, let us move on to the traumatic conditions. Okay, a patient, a balance disordered patient. I'm intentionally, please pardon me if I'm making a mistake, but I'm intentionally using the term balance disordered because I don't want to get into the nitty gritty of the fact that it's a disequilibrium or ataxia. We can always discuss that in later on at a different forum and at a different point of time. The point is that if a balance disordered patient comes to you and is complaining of trauma, I mean, or gives you a history of trauma, a head injury, as an otologist, what is it that you would probably think of? Obviously, the trauma could be accidental, or the trauma could be iatrogenic, as in secondary to a surgery, and say for example it's a post stapes. I mean, most commonly the surgeries, you definitely have the chance of messing up with the vestibule, with the labyrinth, even in a mastoid surgery, but the chances are much higher post stapes. So the trauma could be intentional or iatrogenic, say post stapes surgery, or it could be accidental. Let's look into these two different scenarios one by one. Okay, so we know that if the patient is complaining of an attack of vertigo, or rather if the patient is complaining of vertigo post trauma, post a head injury, we need to think of a temporal bone fracture. Now, the temporal bone fractures, they are of two types: the transverse and the transverse and the longitudinal fractures. Now, the axis along which this decision is taken is the long axis of the petrous bone, which is thus. So, if the fracture is running along the lines of the petrous apex, the long axis of the petrous apex, it's called a longitudinal fracture. On the contrary, if it is orthogonal to it, it's called a transverse fracture. Now, usually the longitudinal fractures, the good part, I mean, God forbid one shouldn't have a fracture, but then the good part is that if the patient has a longitudinal fracture, the chances are that the otic capsule might be spared, which is unlikely in an oblique fracture, as is the scenario here. You can very well see, this is the area of the jugular bulb. This is the posterior semicircular canal. This is the vestibule, and you can see a fracture line extending right up to the tympanic cavity. In fact, the resolution is not very well here. I mean, the color, the color picture color correction is not very well here. But some of the other scans that I had of this patient even had an iso dense shadow, involving this part of the mastoid bone, meaning that there is an associated hemotympanum. But then I'll be able to show it to you in the subsequent section, in the subsequent scans. So this is, as you can see, this is the axis of the fracture, and this is the long axis of the petrous bone. So this is a transverse fracture of the petrous bone, which is liable to causing vertiginous attacks, and also it is liable to causing a sensorineural hearing loss in the patient. Same patient, on the other side, as you can see, again, this is the long axis of the petrous bone. So our fracture is more or less orthogonal. It's more or less orthogonal, and this is the vestibule. Here, you can see the signet ring appearance of the lateral semicircular canal, and you can definitely see the fracture line extending here and here, right up to the attic or the middle ear cavity. So this is another example of a transverse fracture secondary to a head injury. This is another patient, right? This is another patient, a different patient. Coronal view, the right side, at least in this view, appears normal. The right side, though it is not, you can see some fractures lines here as well. But more importantly, right now, what we are concerned with is this fracture line here and here, that is above and below the internal auditory canal on the left side, along with some fracture fragments here as well. And associated with that is this isodense shadow in the tympanic cavity, which indicates a hemotympanum. So this patient too is liable to complaining of vertiginous attacks following the trauma. Same patient, Same patient, slightly different view. You can very well see the fracture line here and the fracture line here. And so again, along with the hemotympanum in the left tympanic cavity. Okay, this is okay. This is the same patient. Unfortunately the picture has been flipped around. So for some reason the picture got flipped around. So you can see that there is a transverse fracture. This is the long axis of the petrous bone. This is the long axis of the petrous bone, and you can see a transverse fracture running through and through the internal auditory canal. You can see the hemotympanum within the periantral air cells, and you can also see a chip fracture here along the upper hilum. So another example of a transverse fracture. Not only that, you can actually see I beg your pardon, the picture is not flipped here. It's a fracture on both sides. You can actually see the fracture line here also. I beg your pardon once again. So this is a patient who actually had a big a major head. I mean, the patient had a major bump from the back of the head, which in fact the impact was such that the patient ended up with a fracture on both sides. Fracture on both sides, here and here. Okay. Again, fracture line running here through the internal auditory canal, very close to the basal turn of the cochlea, and then the fracture line coming out towards the attic area and dislocating the incudomalleolar joint, also causing a hemotympanum. So fracture has to be kept in mind if the patient complains of vertigo attacks following head trauma. What is this? This is the typical Battle's sign that one might encounter in a patient who's had head injury and who's vertiginous. Then this area, this the hematoma, which is caused in the mastoid area in the post-auricular region, is clinically known as the Battle's sign. So this is a picture demonstrating the Battle's sign in a head injury patient. From injury, rather from accidental injury, we move to the surgical injury, and that is post-stapes surgery. Now, you might not always be fortunate enough to have your stapes illuminated like that, for the simple reason that it all depends upon what what. Just a moment, please. Sorry. So it all depends upon the opacity, the radio opacity of the material that you've used for your piston. A Teflon piston might not be radio opaque. This is a piston which partly had titanium, and that's the reason why we are able to visualize it. And as you can see, this is the area of the foot plate. This is the vestibule, and so this is the piston should have been partly inside the vestibule, but since we can see this hypointense shadow here, it clearly indicates that the piston has lateralized, as a result of which the patient has developed a perilymph fistula. This iso-intense shadow that you see here is because of the fluid of the perilymph fluid coming out into the middle ear cavity, and that the patient has developed a perilymph fistula, which is making the patient vertiginous. So post-stapes surgery, sudden deterioration of hearing, and attacks of vertigo, you always have to think of the fact that your piston might have lateralized, the piston might have dislocated from the stipidotomy, and from the stipidotomy opening, and it has led to a perilymphatic fistula. Okay, so that's the case of post-surgical post-stapes surgery scenario, wherein the patient can complain of vertigo. Okay, leave behind the middle ear and move a little deeper inside, and we pick up a condition, or I mean, for which there are hundreds of publications and various modalities of, or rather there's a lot of confusion. What should be considered under benign vestibular paroxysmia? Which particular patient should be considered a patient of benign vestibular paroxysmia? And I'm not going to get into the details of all that, but we know that the patient has short-lasting multiple attacks of dizziness, of spinning, non-spinning, as per the latest recommendations of the Barani Society. And it could be positional, it could be associated with head turning, so on and so forth. Hyperventilation could lead to could lead to the worsening of the attack. There are multiple attacks, sometimes 30, sometimes 40, maybe more than that, less than 2 minutes, 5 minutes. We're not going to get into the discussion, but the idea is a patient with this kind of a history, and you obviously have to keep benign vestibular paroxysmia in mind. And obviously the only investigation of choice there is an MR. Whether you do a conventional MR or you do a conventional MR along with an MR, arteriography depends upon you, and what you expect, what one expects to find there is a vascular loop. So this is one patient, and there are various protocols that you can follow for the MR, but the idea is that you have to have a protocol where you can actually see the nerves and the blood vessels together. Okay, you need to see the nerve and the blood vessels together. So the usual protocols that are available are either a 3D CIS or a 3D Fiesta. Friends, I am a routine otologist. I'm not a radiologist. So if you ask me about the details behind the physics behind all this, I'll not be able to explain it to you. But yes, do collaborate with your radiologist. Do talk to them. Do tell them what is it that you wish to look for, and your radiologists would help you decide, or rather, the radiologist would decide what's the best protocol to determine whether the patient is having a neurovascular cross compression or not. So here you can very clearly see a loop of, usually it is the ICA, that is the anterior inferior cerebellar artery, which is the offending vessel because it's in close proximity to the 7th, 8th nerve complex. But then the pica or even the basilar artery, or for that matter some anomalous vein, can also be responsible for it. So as you can see, there is this loop of ICA which is very close both to the meatus, and the loop is entering into the internal auditory canal. And we know the contents of the internal auditory canal are the superior inferior vestibular nerve, the cochlear nerve, and the facial nerve. So if the patient is solely having vertiginous attacks, then it's the neurovascular cross compression is mainly involving the vestibular nerve. But in case the patient is having auditory symptoms also, either a hypoacusis or tinnitus, then the chances are that the vascular loop is also compressing upon the auditory nerve. And if the patient is having an associated facial nerve symptom, say like a hemifacial spasm, then the loop is probably compressing upon the facial nerve as well. Now the normal theory, I mean, I would request you to look up the paper, the publication from Barani Society, if you wish to read the protocol that has been designated to diagnose benign vestibular paroxysmia. But it is usually said that it's the first 15 millimeters of the nerve which are more prone to causing a vestibular paroxysmia attack, benign vestibular paroxysmia attack, if it is being compressed by the artery or the blood vessel. Though my personal experience has been that I have even seen otherwise. Okay, anyway, more of that later on in a different forum. But you can see the same patient, you can see the vascular loop here and the vascular loop here, and that's the vascular loop here, that's the blood vessel here. So it has a tortuous, a circuitous route all around the 7th, 8th nerve complex, leading to a diagnosis of benign vestibular paroxysmia. Same patient subjected to an MR arteriography. That's the basilar artery, that's the vertebral artery on the left side, the fourth part. As you can see, this ICA extending right from the basilar artery, having a hairpin bend close to the internal auditory meatus and going back. So that's an example of an ICA loop compressing, causing a neurovascular cross compression. Same patient, I beg your pardon, this was an axial view, and this is a coronal view. That's the third part of the vertebral artery, the fourth part of the vertebral artery, that's the pica, that's the vertebral artery contralateral side, that's the basilar artery, that's the scars, the superior cerebellar artery, that's the posterior cerebellar artery. And you can see the ICA coming out from the basilar artery and extending right up to the internal auditory canal, thereby leading to symptoms of benign vestibular paroxysmia. different patient, different view. Just for your information, this was a siesta view, a fiesta view, and this is what is called a space view. Again, your radiology friends would help you with that. So this is a space view, and very clearly what you see is the basilar artery here. This is an actual view. You can see the aorta coming out, going entering into the internal auditory canal, looping around the 7th 8th complex, and then coming back at the root entry zone of the vestibular nerve. In fact, this is a patient who's currently under my treatment, and the patient has all three symptoms. The patient has hypoacusis, more of the higher frequencies in the left ear. The patient has tinnitus, and the patient has attacks of rotatory vertigo, multiple attacks, and this patient has responded very well to 400 milligram per day, that is 200 milligram twice a day. The patient has responded very well to 400 milligram per day of carbamazepine, and obviously his hearing will not improve, but his tinnitus has gone down, and definitely his vertiginous attacks have gone down. Same patient, this is a 3D TOF, time of flight MR angiography, arteriography. You can see the entire vascular loop with its hairpin bend in the internal auditory canal. And obviously, see, this is the disadvantage of doing an arteriography via V, the advantage of doing fiesta here and an arteriography here, a space sequence here, and an arteriography. While the arteriography gives us the entire vascular loop, it does not show us the 7th, 8th, the nerves, and therefore it's not a composite view where you can actually demonstrate the neurovascular cross compression. Now, this is a case of bilateral vascular loops coming in close proximity to the 7th, 8th complex, though this patient actually had symptoms of the loop compressing onto the left side rather than the right side. But then this is another dilemma, especially when surgery is being recommended, though it's not as popular as it used to be earlier. Janetta, Muller, they are that's the group that had been a strong advocate of microvascular decompression for this particular problem. But then the dilemma here is, in case it's not very clear as to which side is the nystagmus beating, in case the neurovascular cross compression, it's not very clear which side is the neurovascular cross compression actually, then in cases where there is a bilateral vascular loop, it's very difficult for you to decide, for the clinician to decide which is the side that should be, which side of the patient should be subjected to the microvascular decompression. Okay, yes please.
Yeah, we have only less than a minute, so we're going to take a 2-minute break, and we're going to restart with the second webinar link, okay?
Perfect, because this is exactly the point where I wanted it to go into the second session.
Perfect.
Perfect. Absolutely perfect. So I'll just log out and log in from the second link, right?
It's going to take me 2 minutes just to finalize the recording of this one, and then directly we can move to the second one.
Okay, I'll just stop sharing for the time being,
Perfect.
right? Perfect.